Again, thank you for the opportunity to speak at the conference. So I'm going to be outlining the 5 ICU safety and quality concerns that I see for physiotherapy. These include things like education, supervision and leadership, staffing and resources, team integration and culture, and patient care transitions. So I guess first, just to give you a bit of information about the practice that I do. I'm from RBH. It's a 27-bed ICU. We've got a 4 to 6 bed elective surgery high dependency unit, and we have a tracheostomy management service, which is a fantastic resource. So all up, the ICU physio team is about 5.1 physios. That's Monday to Friday. Of that, there's only really 2 stable people in that team. So there's myself as the team leader. I also have to outreach to surgery, which is the 60-bed ward with more physios. We've got the tracheostomy management service physio who's stable, and then all the other physios are rotational, and that's either 3-month rotations for our new grads or 6-monthly for the rest of the staff. So they rotate every 3 months, and most of those staff would have between probably 2 and 5 years experience. We do provide a weekend service, so it pretty much is a fairly continuous service, but we do limit heavy rehabilitation that we offer. And unfortunately, some of the physios that contribute to the service lack the ICU passion that we have in a lot of the other teams. So we do have to draw upon orthopedics and neuro and outpatient service physiotherapists, so the expertise and specialists in those areas to contribute to the weekend service. On-call service is 24 hours. We actually have a very high call-in rate, so about 80% of on-calls involve the physio coming into the hospital. This is often to ICU. They are quite complex patients at times. 30% of the time that will require the treatment to be provided past midnight, and that then results in fatigue leave in the department. And we see the needs are actually increasing because of things like organ donation and potential roles in organ donation. That's something we've seen in our unit. So our department training requirements are quite high to maintain the physiotherapy workforce services to the ICU. Our department of the Royal Brisbane, we're one of the biggest departments in Australia. So we've got about 100 FTE, which is about 130 people that actually, when you take into part-timers and everything like that. So about 50 of those contribute to the ICU service, and about 20 of those every year either leave, new grads coming in. So about 20 of those we actually have to orientate to the ICU. At the moment, our orientation procedure is a 1-day offline process. We don't have any preceptor arrangements or offline teaching provisions in our wards, so we have to make that time from within our department or departmental resources. And we're finding as we keep going, and we've heard this morning already about the junior element to our staff, that staff really are wanting to come back and do more refreshers because they just don't have that confidence to work in ICU. They need to have their skills up to date. So we do try and give people an orientation to the unit on the day. We go through medical nursing and allied health staffing. We have to orientate to the ICU bed space. And just remember that for a lot of the physios, this is the first time they've actually been into the ICU. We have to introduce all the skills that they're required, make sure they're aware of mechanical ventilation and all the monitoring, talk about and go through our respiratory and techniques and mobilisation. Introduce them to the typical flow of a day for a weekend and Monday to Friday service. And there's also many other aspects of non-technical skills that make for a efficient, safe delivery of physiotherapy services that we have to try and cover. So it's more of an orientation, and we build upon it with experience. But we certainly can't guarantee that our physios are going to be able to work independently in our environment after that day of orientation. So we do have a process for the structure and support for the provision of basic training for physios, but I'd say it's not well resourced. And our service delivery is very heavily reliant on the junior physiotherapy staff to provide services. And as I said, staff often don't feel confident about working in the ICU independently. So you see this particularly for things where you've got that more difficult patient who you can mobilise. Perhaps it is that ventilated patient that's able to get up and do a stand or walk away from the bed space. But even just patients who aren't ventilated and have heaps of attachments. But we sit in conferences and we often hear about the message of early goal-directed mobilisation in intensive care unit is feasible and safe. I'd say that it is, yes, feasible and safe, but it still requires a very certain degree of education and training, and that's for all staff involved in that process. My question is, do you know what education and training your nursing and physiotherapy staff have regarding mobilisation of intensive care patients? Are there specific training pathways or elements that they're doing. And what's the actual education that you know about for the requirements for your physiotherapist to work in your ICU? This is from Carol Hodgin, and just a table explaining some of the barriers and facilitators to mobilisation. And we all have, whether it's about prescribing a drug or doing a procedure in ICU, there's a long list of things that we need to consider, and it's all these elements that we have to try and teach and make sure that our staff are aware of. So they need to know about those physiological instabilities, what's happening with sedation and delirium with this patient, what analgesia do they have, what are the patient goals? We're getting down to that level of talking with the family and the patient about what we're going to do. What can they do in this unit? What's the team culture regarding mobility? How do we ingrain that into things like ward round or team meetings? Who do we see as the leaders in the department for it? What equipment do we have? So there's heaps of factors we're trying to educate staff with. So we do have solutions. We've certainly as a profession developing things. So we've got guidelines to outline educational programs for physiotherapists, and I was involved in a Delphi study to try and put together minimum standards for physio working in critical care settings in Australia and New Zealand. And we again have things like the literature producing great documents that are trying to show precautions and contraindications to mobility in a very user-friendly process. So things like the Carroll's guidelines with the traffic lights. In Queensland, we've also tried to standardise workplace training across Queensland Health sites. So there's recommendations for the minimum training sort of requirements for intensive care competency. And part of that is actually completing an e-learning package called Physiotherapy and Critical Care Management. So staff have to complete that and do an annual competency which involves a multiple choice question. Locally, I know I try and we've moved towards competency-based assessments, particularly around things like equipment, so cough assist machines, or mechanical insufflation, exsufflation, non-invasive ventilation. Staff have to actually come to an education session, but then also be assessed on a competency-based evaluation each year to demonstrate that they're still able to use that equipment and know all of its nuances. Certainly using a lot more simulation training, particularly to try and demonstrate and have people that do hands-on practice around more complex mobilities. So that's a really good avenue to use. And we do have more comprehensive introductory courses available to us. So there's a Pac-Man 2-day course which is run extensively in Queensland. It's also been adopted in Wollongong in New South Wales, and in August we're hopefully taking it across to New Zealand as well. And APA is just about to launch a Level 2 Intensive Care Physiotherapy course. Again, it's an introductory course. It's actually on next weekend, and then we're running it in November in Melbourne. However, leading into that's good for the introduction to ICU, but we also need to support our leaders and the people that provide supervision to the ICU physiotherapy team. And there really are limited opportunities for physiotherapy to staff to actually remain in the ICU and build those advanced skills. So if we're wanting them to really understand the intricacies of delirium or sedation, all these things with mechanical ventilation, different techniques that they might be involved in, but also those elements that help you out in the ICU with communication and resilience. We really don't give a lot of staff the opportunity to be able to build these. There's also very limited advanced training pathways for physiotherapists in critical care. So we do have a college, but there's only 7 physios actually who have completed that for cardiorespiratory physiotherapy, and there's quite limited master's education programs. In fact, there's only one that's only recently become available. So leadership often falls to a single senior physiotherapist in the ICU. In smaller units and regional units, the lead physiotherapist may actually be quite junior. And obviously supervision is essential for doing a lot of things. It's the education and training of that staff, sharing experiences, practical tips on the job, situational awareness, debriefing, conflict management, and guidance with those complex patients. So if it's down to one person, then you do have to wonder, it's what I always wonder when I sit here sometimes, what's happening back at home and who's providing that leadership for those more difficult patients for the team at the moment. There's great avenues for physios to be used in leadership roles within our ICU community as well. So just some examples. We're obviously very good and strong advocates for mobilisation. So having a physio do education with the nursing staff and physio team and medical team about mobilisation. We've engaged with oxygen therapy and humidification, airway suctioning, and tracheostomy management, and trying to do that not just through lectures and practical, but also things like simulation. Well ingrained, John mentioned yesterday, that we've actually participated in the ICU quality improvement and research programs. And we can also do outreach. So I think it's important for us to be considered in the outreach model from ICU within the hospital. But we also, Prince Charles and myself, have been doing outreach within Queensland. So we've helped to support through telehealth, linking in with services where the physios are quite junior, they don't have any senior support, and doing that for places like Rockhampton, which has been quite successful. So we do need resources to do this, like everybody. We all feel that we're resource deprived. And I just thought it'd be interesting to review what we currently have to support our staffing arrangements. And if we look at the College of Intensive Care Medicine guidelines for minimum standards in ICU, it outlines the medical and nursing workforce. There's recommended staffing ratios. It recommends information about educational requirements for these professions and education support. For the medical staff, it also does include things like access to leave and while maintaining clinical cover at all times. There's other specific recommendations for nurse educators, equipment officers, data managers, research coordinators, ward clerks, and secretary for the medical staff. So you can probably see where I'm going with this. But for allied health and pharmacy, when we get it to those, dietitian, OT and speech for a level 3 unit is reported as access as required. Physiotherapists and social work is on request 24 hours. So we don't actually have any recommendations within our College of Intensive Care Medicine guidelines for the ratio of allied health per pod or ICU bed, education and training requirements for them, and their potential roles in interprofessional learning or being ingrained into the culture and system of our units. And we've heard over the last day and a half about how everybody in the team can make some significant contributions. So we're definitely part of that team, and I think we just need to think about whether we're reflecting this and whether perhaps we need to do this a little bit more. If you look at the UK Intensive Care Society guidelines, even just looking at the index, you can see that they've actually incorporated a lot more information and guidelines. This whole section is dedicated to the different allied health team that is involved. And they've got recommendations in there that there should always be an identifiable lead physio who can be accountable for the service, which I think is what we're trying to do, instead of putting it in paper. We've got that physiotherapist involvement within ward rounds, and it must incur every day, including weekends and national holidays. So they have to have daily input from pharmacy, physiotherapy, nursing. Critical care team must have a physiotherapist with adequate experience and seniority, and that's to provide guidance with complex patients to the team, and participate in the multi-professional team in wider involvement. It has to address particular parts of physiotherapy practice, and they do have a suggested ratio of 1:4. So in Queensland, we have actually developed, around 2010, we developed a physiotherapy workforce planning guideline. It's been supported by the Directors of Physiotherapy throughout Queensland. And we recently reviewed this in the last 2 years and just asked for feedback in how it had been implemented from physiotherapists who'd used it. And unfortunately, some of the feedback wasn't positive. Overall, it was great to have the tool, but they felt in actually trying to implement it that sometimes they didn't get the traction for the support of the senior staff. So that was sort of taken out by hospital managers. And even perhaps our own ICUs impaired the process of being able to use the tool because they couldn't get exact numbers of beds. And I know that's always a bit of a battle even for the intensive care unit and the hospital managers. But it was difficult to use the tool because we couldn't get that information provided in an accurate way. And I'd have to say from my experience over the 20 years, probably more recent 10 years of trying to help people across Australia and New Zealand with their staffing, that this is fairly much the way it happens. The funding proposals for an ICU bed really aren't that inclusive of the wider allied health team requirements. Sometimes people consider it's a different pot of money, so you guys access your pot of money, we'll keep focused on ours. And I certainly had the personal experience where we had 8 beds, 4 ICU, 4 HDU, that were opened with no additional allied health staffing. So this then impacts on what people can do during the day. They may not be able to do ward round, they might not be able to see all of the patients, but might be really prioritising to high-risk patients, and they may not integrate into those things like a QI and education within the unit. There's a lot of units that provide limited or no cover, so if a member of their ICU staff go on annual leave, then it's up to the team to share that burden, so that can stretch your services. And on-call services, 25% of Queensland Health hospitals don't actually provide those on-call services, and there's units with spinal cord injury, which is a fairly resource-intensive environment for a physio to be in, but some of those pretty much cease at the end of the day because of lack of on-call. So we really do need collaboration. It's essential for reviewing, staffing and resourcing, and it requires a commitment from leaders in the Australian intensive care community, that's all of us in the room, to review the current guidelines that we have and truly make sure that they reflect the multi-professional involvement in the ICU. And there's an element of trust we also have to do. I think, unfortunately, I've felt that other professions have wanted to set what we, as a profession, should have. But I think we really actually need to trust each profession to come up and outline their own ICU service requirements. The next one is team integration and ICU culture, and ICU definitely has a strong leadership presence. I think that the ICU consultants need to be commended in terms of their presence in the intensive care unit when they're clinical, and not many professions probably or other areas do that as well as the intensive care. So that places heavy demands on our leaders. But we also know that strong relationships exist between high quality teams and the working relationship within that healthcare team. So they need to have shared goals, shared knowledge and mutual respect among colleagues. A culture of teamwork is often recognised in the literature about things that affect the implementation of early rehabilitation into ICU practice. So again, just asking yourself a question, what's your working relationship, teamwork and culture with your allied health team? So when you're doing medical and nursing ward rounds in the morning, are they allied health actually there? Are they integrated into your morning rounds? And by integration, are they the people that are actually behind you that never say anything? Are they the passive people? Sometimes the nursing staff, there's nursing literature as well talking about they're on the ward round, but they're actually not contributing to the ward round. So are they passive participants or are they actively engaged? And how do you acknowledge their presence and empower them to continue? I know the consultants that bring up mobility at the end of their piece per patient and ask, okay, what are we going to do with this patient today to mobilise? That puts a skip in my stride for the rest of the day, and I do everything I possibly can to get that patient up and mobilised to the level that we were sort of discussing. So we do really need to try and look at ways that we can set shared goals around mobilisation and respiratory management if it's relevant. And you can use ward round if you think in your unit you're not doing enough mobility. There was a nice study that was done where they showed mobility goals matched about 90% of what they predicted or planned at the beginning of the day. As long as at the beginning of the day they sat down and said, what's our goal for the day? How are we going to achieve it? Write down that goal, and then the clinical team worked towards that goal. They didn't put any extra resources into the unit to support that mobility. They simply planned and wrote down the goal. All this communication, even if it's just on ward round, I think it also, we've heard it a few times, that it empowers staff to be able to feel that they can go and approach you as well. So I think that's really important for them to be able to feel comfortable to approach you about management plans, to seek clarification, and also alert you on clinical deterioration. And I'm talking about both medical and nursing workforces here. And just quickly, with the ICU leadership as your allied health integrated in there. So I am very lucky. I do get to attend our quality improvement meetings. Lucky, yes. Quality improvement meetings. We contribute to interprofessional education programs. But probably an area that I feel that we sometimes do lack is we've only just come into some of the leadership meetings, and I've certainly never been invited to a strategic or operational planning meeting for the unit. But I think that's where potentially that buy-in and input is also very important. The last part was just to mention ICU Outreach and ICU follow-up clinics, and these are very topical in our ICU community. And I just wanted to point from the perspective of physiotherapy, we probably do have a role in trying to provide this. We do a lot of ad hoc reaching out from the ICU team out to support the wards. PA Hospital's currently got a project looking at this as well. But it's a great role for some of these senior physiotherapists, and they're providing clinical support and educational support. We've certainly seen the benefit with our tracheostomy management service, but also we'd see a benefit for those patients transitioning to the ward, reviewing charts, just seeing how patients have gone at times when you've been alerted. Sometimes there's a delay of 2 to 3 days before the patient gets to the level of mobility that they left ICU with. So they might hit the ward, junior physio, some complex mobility, they're not quite sure how to get that equipment. A day passes, and before you know it, you've got that 3 to 4 day gap before anything actually happens. Complex patients with complex respiratory management, making sure that treatment is continued through. And potentially we get calls now to calls at times. They're ad hoc, but we are actually having to intervene there. And I think there's a potential role for physio in reviewing those patients of concern who might be involved in those. So patient care transitions would need us to really look at our staffing as well in terms of being able to provide staff who can do evening shifts, looking at on-call services, maybe taking a 7-day-week service rather than prioritise weekend services for physiotherapy, and looking at rehab needs. So my 5 top, I think, are all fairly much shared. You could put nursing and medical with those same sort of key areas, and I hope this just gives you a perspective from an allied health and make us realise that we have to do this together in a multi-professional way with support. Thank you.